Hi, I'm Dr. Robert Kaufmann, and we're about to go beyond the terminus. Today we're talking about when and how to use antibiotics in endodontics. Everybody's been there. The patient calls you with a toothache, tooth that's thermally sensitive, and they're having difficulty eating. They have irreversible pulpitis. Your schedule is busy, and this emergency is an unwelcome interruption in your day. So what do? For many clinicians, the answer is simple. Write an antibiotic prescription, give it to the patient, and tell them to schedule an appointment at a future time. But is this the responsible thing to do? Is this kind of prescription justifiable? And is it done more for your convenience than to treat the patient? The wholesale use of antibiotic prescription is an effortless method of getting patients out of the office or dealing with symptomatic telephone calls must be condemned. Understanding pathology precludes the use of antibiotic therapy in vital cases. It is ironic that clinicians who prescribe antibiotics for thermally sensitive sick pulps don't recognize that part of the pathology involves compromise of circulation to the pulp. Antibiotic therapy is of no value in the case of pulpitis with a vital pulp. Antibiotics rely on the attainment of adequate concentration of medication via the circulation. With circulation compromised by inflammation, there's no way for this medication to reach the affected area, that being the most coronal or radicular pulp. The most critical management decision facing the clinician dealing with an emergency pulpitis is whether or not periapical symptoms are present. Check out my 3-part presentation on handling endodontic emergencies. Part 1, reversible pulpitis. Part 2, irreversible pulpitis. And Part 3, the acute apical abscess, for more information on how to handle your emergencies. There is no scientific basis for giving antibiotics as a prophylaxis or as a just-in-case prescription for patients that have an endodontic involvement of a vital or necrotic pulp. Antibiotics should be used, but only in limited cases. Let's examine what those cases may be. Dr. Ashraf Fouad in the Pharmacology Journal, December 2nd, 2019, summarized antibiotic use in endodontics very succinctly. The most important strategy, he said, is prompt dental management of the condition or referral for endodontic management of the patient. For immunocompetent patients with pulpitis or pulp necrosis with symptomatic irreversible pulpitis or localized acute apical abscess with no evidence of lymphadenopathy, fever, malaise, or fascial space involvement, localized treatment does not need to be accompanied by an antibiotic prescription. We may choose to give antibiotics to patients with an acute apical abscess and systemic involvement, or systemic disease that compromises their immune response. An antibiotic prescription is also probably indicated for the rare patient with a localized acute apical abscess who will not receive immediate treatment, but will be referred to another practitioner for future appointment and management of the case. It's not indicated for routine pulpitis or toothache. So what changes have occurred recently? For patients who are not immune compromised, beta-lactam-based antibiotics, primarily amoxicillin 500 milligrams or potassium PenVK 500 milligrams 3 times a day for 3 to 7 days remains the first line of effective antibiotics for patients in whom antibiotics are indicated. Amoxicillin has a wider spectrum than penicillin VK, but tends to be more effective against gram-negative organisms. It is also the drug of choice when pre-appointment antibiotic prophylaxis is required for medical reasons. In cases that are not responding to penicillin VK, we can add metronidazole 500 milligrams 3 times a day to that prescription. If the patient is not responding to amoxicillin after the first few days, we can add clavulin 125 milligrams. For the patient who is allergic to penicillin, the patient needs to be asked about the type of reaction that they received. True allergy is defined only for patients with a history of anaphylaxis, angioedema, or hives. If the patient claims a reaction to penicillin but didn't have these reactions, oral ceflexin 500 milligrams 4 times daily for 3 to 7 days would be indicated. For the patient with a true allergy to penicillin, the primary alternative antibiotic recommendation has changed. It used to be clindamycin. It is now azithromycin with a loading dose of 500 milligrams and then 250 milligrams for 4 additional days. Clindamycin now has a U.S. Food and Drug Administration black box warning for Clostridium difficile infection, which can be fatal. Therefore, it's only indicated if the patient cannot take azithromycin. For all patients on antibiotics, the antibiotic treatment is discontinued as soon as definitive treatment is performed and improvement of the patient's condition occurs. And that's in as short as a 3-day period rather than the full course of the prescription. You can also find 2 really good references in the Endo files cabinet of my website, www.endoexperience.com. Search the cabinet for the terms 2019 AAE update on antibiotics, and a second one, AAE Systemic Use of Antibiotics 2017. You can download those PDFs for free from my site. The continued irrational use of antibiotics as a scattergun or do something treatment for symptomatic patients contributes to the proliferation of antibiotic resistance for us all. The consequences will probably not be apparent to clinicians in their middle or later career years, like me. But the problem will no doubt escalate in the future as bacteria become more and more resistant and we are left with fewer effective drugs. Those of us prescribing in a haphazard manner may well be responsible for a situation where our children and our grandchildren have fewer and fewer alternatives for treating serious bacterial infection and other more critical areas of the body. Responsible use of antibiotic therapy is part of good dental practice. Clinicians who are unwilling to take the time to properly diagnose and treat a problem, or who are not able to make a definitive diagnosis, should opt for the referral. Use of antibiotics as a treatment for problems of unknown etiology is poor clinical practice. Antibiotics are not chicken soup, and clinicians shouldn't use them in that manner. When in doubt, don't reach for the prescription pad. Refer the case to a specialist. Remember, when we do the right thing, our patients get better, but so do we. Thanks for listening, and join me again when we take another trip beyond the terminus.